A mother in Colorado describes the moment she knew something was wrong with her son. He had been using cannabis for a couple of years, legally purchased from a licensed dispensary, but what he was buying wasn't anything like the marijuana people talked about in the 1970s. The THC content exceeded 90%, and one day her son stopped recognizing reality, and in clinical terms, we call this psychosis. His name is Zach, and when he was a teenager, his mom, Amy Wadsworth, said that he was the kind of kid that parents just did not worry about. He played sports, he cared about his health, he stayed away from drugs and substance use generally, and then when he went off to college, he started using cannabis to cope with social anxiety and as a sleep aid to help him with insomnia. Within months, Amy Wadsworth's son was calling home in the middle of the night, disoriented, terrified, and paranoid. He was eventually diagnosed with a severe cannabis use disorder, or what we would call cannabis addiction, and he cycled through episodes of psychosis in and out of hospitals and treatment programs across the country. And since that time, Amy Wadsworth, his mom, has spent years testifying before state legislatures, trying to get people to understand that the cannabis being consumed today is markedly different from the cannabis that has been studied in clinical trials in decades past. Hello and welcome to the Dr. Suzette Glasner podcast. I'm Dr. Suzette Glasner, and today we're talking about cannabis use and specifically what is currently known about the link between cannabis use and mental health, because there's some very new research just out this year that really sheds light on that relationship. There really is a wide gap between public perception and clinical evidence, and I want to help you understand it. So first I want to talk about the perception problem, which is that the perception of risk related to using cannabis and using cannabis regularly has decreased over the past couple of decades, especially among young people. So meaning young people don't perceive cannabis use as especially risky or dangerous. And now that matters because that is associated with drug use. When something feels less dangerous, people use more of it, and younger people use it earlier, which we know from research can have profound effects on brain functioning and future mental health. So there's this sort of imbalance in the perception of the potential benefits of cannabis use, for which people feel that there could be many, versus its risks. And that gap has real consequences. So I'd like to ground the conversation in what cannabis-based medicines are legally approved to treat in the United States, because this is also widely misunderstood. There are currently a very small number of FDA-approved cannabis-derived medications. Epidiolex, which is a purified cannabidiol or CBD oral solution. This is approved for very specific, severe, and rare seizure disorders that can be resistant to traditional forms of treatment. Then you have Marinol, which is also known as dronabinol, which is essentially synthetic THC. And this is approved for nausea and vomiting caused by chemotherapy, and for AIDS-related anorexia and weight loss, so to help stimulate appetite. Then there's Sesamet, and that's another synthetic cannabinoid called nabilone. This is also approved for chemo-related nausea. And that's the complete list: severe, rare, and treatment-resistant seizures, chemotherapy-related nausea, and AIDS-related anorexia. And now, here's the contrast. Surveys consistently show that anxiety and depression are the top two reasons Americans report using cannabis for medical purposes. So there's this massive disconnect between what cannabis is actually approved for in terms of treatment and what people believe it treats. And that disconnect can have consequences, and a major new study documents just how serious those consequences can be. There are actually two studies I want to walk you through, but the first one was published in the Journal of the American Medical Association, or JAMA, Health Forum earlier this year. And it was out of Kaiser Permanente in Northern California. This is by far one of the largest studies of adolescent cannabis use in our scientific literature. They studied nearly 500,000 people, adolescents between the ages of 13 and 17. They were followed over time to investigate whether cannabis use during adolescence affected the risk of being diagnosed later with a psychiatric disorder. And the answer across all the categories that they examined was yes, there is a relationship between cannabis use in adolescence and the development of a psychiatric disorder later on. And the numbers were quite striking. So adolescents who used cannabis had more than double the risk of developing a psychotic disorder, and the same level of risk, about double the risk, of developing bipolar disorder compared to people who did not use cannabis during those ages of 13 to 17. There was also increased risk of depressive disorders as well as anxiety disorders, but the strongest association was between cannabis use in adolescence and psychosis or bipolar disorder. Importantly, in most cases, cannabis use came first. So it preceded the psychiatric diagnosis by an average of 1.7 to 2.3 years. So that sequence matters because we're not primarily seeing kids who were already depressed and then turned to cannabis to cope and then developed a psychiatric disorder. The cannabis use came first, which suggests that it has a causal influence on the development of a psychiatric disorder. Now, there are limitations to this study. So the study shows an association, which means there could be some factors other than cannabis use that differentiates the two groups and might partially explain the results. So examples of factors that couldn't be measured or weren't measured in this study are adverse childhood experiences, which we know increases the risk of cannabis use disorder and related psychiatric disorders, parent mental health, and genetics. All of those could play a role. That said, the findings remain statistically significant even after they adjusted statistically for some of the factors that could influence that outcome of having a psychiatric disorder. So, for example, they adjusted for or controlled for a history of psychiatric disorders. They adjusted for a history of other substance use apart from cannabis to see if they could isolate how much of this was about cannabis versus other problems that young people have, other psychiatric problems, other drug use problems. Could these psychiatric disorders be partially explained by those things? But they found that it was not, and that they still saw that statistically significant association between cannabis use and later bipolar and psychotic disorders, as well as depressive and anxiety disorders, even when they removed the effects of having other substance use and other psychiatric disorders. So the effect sizes are large. These are findings of kind of a large magnitude. The sample is very large. And then that temporal sequencing of what came first, the cannabis use coming before the psychiatric disorders, really strengthens the argument that these are causally related, that the cannabis use has a causal role in predicting a psychiatric disorder later. Now, a second study that I want to tell you about, in March of 2026, a team of researchers published a systematic review. They reviewed a ton of studies, and they were looking at one question, which is whether medicinal cannabis actually works for anxiety, depression, or PTSD. Now, they looked at a variety of other conditions as well, but because we're talking broadly about mental health and depression and anxiety for today's episode, I'm going to focus on the findings in depression, anxiety, and post-traumatic stress disorder. They reviewed randomized control trials, which are the sort of gold standard for clinical evidence, and their finding was pretty clear. They did not find convincing evidence that cannabis-based medicines effectively treated anxiety, depression, or post-traumatic stress disorder. Now, that doesn't mean that no individual study has ever shown any effect. What it means is that when you look at the totality of the rigorous trial evidence, it just doesn't hold up that cannabis treats these conditions effectively. So part of this is because the available trials have a lot of weaknesses in the way that they've been designed. They're very small sample sizes. They look at anxiety and depression symptoms over a very short time frame. There's a lot of variety in the different formulations of cannabis that were used. So it makes it really hard to draw reliable conclusions. And because the quality of that evidence is so low, there's not a whole lot to go on. But of the evidence that does exist, the researchers found that there was not clearly a connection between using cannabis medicinally and showing consistent improvements in anxiety, depression, or post-traumatic stress disorder. So this is important because, again, the two things that most Americans believe cannabis helps with, which is anxiety and depression, are not really supported by clinical trial literature yet, even though it's being widely used for those purposes. And one of the reasons that this was concerning to the authors and is concerning to us as a field is that we do have evidence-based and effective treatments for these conditions. We have therapies that are effective. We have medications that are effective for anxiety, depression, and PTSD. And so when people are using cannabis in place of those treatments, they're actually delaying the use of the most effective treatments we have. And in some ways that could prolong and worsen their illness potentially in the meantime. So the third problem that I want to talk about is the potency problem, which Amy Wadsworth has been talking about extensively, which is that when Americans picture cannabis, even those who used in college decades ago, they're picturing a product that really no longer exists in the commercial market. Cannabis flower sold in dispensaries today typically contains 15 to 20% THC or higher. In California, the average THC content in flower exceeds 20%. Concentrates like waxes and dabs and vape cartridges can reach 80 to 90% THC. When you look back to the 70s and 80s, cannabis typically contained THC in the single digits. So we're really not talking about the same drug. So putting that into context, the research that's showing the doubled psychiatric risks was conducted on contemporary cannabis users. So those are people using today's high potency products. Amy Wadsworth's son, Zach, was using concentrates with over 90% THC. She describes him becoming progressively paranoid and then psychotic before receiving a diagnosis of cannabis-induced psychosis, and he is now in recovery, but it's been a tough road. So I'm going to bring together 3 takeaways that I would like you to leave with today. The first is that our perception of safety of something drives our behavior. If we think something is dangerous or risky, we may be less likely to do it. If we think it's safe, we may be more likely to do it. And so the perception around cannabis has really drifted from reality, and that while there may be some potential therapeutic benefits that, even if they're not borne out in all of the studies, some people do subjectively experience, it's not without its risks. It does carry serious risks of cannabis dependency and the development or worsening of certain psychiatric conditions like anxiety, depression, psychosis, and bipolar disorder. The second takeaway is that cannabis is not an evidence-based treatment for anxiety, depression, or post-traumatic stress disorder. The FDA-approved cannabis applications are pretty narrow and specific. It's childhood epilepsy, chemotherapy-induced nausea, and AIDS wasting. And the most common reasons that Americans are using cannabis medically have not really been validated in clinical trials as of yet. So the gap between what people believe cannabis can treat or be helpful with and what it's actually approved to treat is quite large. And again, using an unvalidated treatment can delay using a more proven effective treatment. And then the third takeaway is the importance of this potency issue. When we see data that is showing double the risk of psychosis and bipolar disorder in adolescent cannabis users, we're seeing data on contemporary cannabis use. And this is cannabis use of a much higher potency than we've seen previously historically. So the bottom line is I'm sharing this with you because people deserve to make decisions about cannabis based on what the science shows. I'd like to link to all 3 studies that we discussed today in the show notes. And if you found this episode useful, please share it. This is a conversation that really does need to happen more widely. I'm Dr. Suzette Glasner. Thank you for being here. I hope you learned something valuable, and I look forward to seeing you next time.